Hello guys, I'm here in Marshall Island. I just have nothing to do right now. I finished rounds in the morning. I have an interesting case to tell you for those medical health workers or medical interns, nurses that wanted to share something interesting case to learn about. I think this is a good case report case that could be shared. So I just want to share it with you. So I'll give you the story of this patient. Since I have more time to chill as of today. Today is Sunday here, and just have nothing to do. So probably I would share this scenario. So basically, I am trapped in one island. There's no huge hospital or tertiary hospital. Our hospital, just to give you a background, is just 50 bed capacity. You can only do some basic blood tests, nothing more. We have no radiologist. We have no CT scan. So what can you do? Just do the best that you can with your best knowledge that you can help with the patient. So that's the most important thing. So to give you a background, I'm giving you a 56 years old gentleman. He is a smoker, an alcoholic drinker as well. He was diagnosed with liver cirrhosis, severe portal hypertension, secondary to fatty liver disease in 2018. According to my colleague, March of 2021, he was admitted because of symptomatic ascites with large clinical ascites in that month. Right now it's already June 21. So this patient I just handled 3 days ago. So to tell you a story about this patient in March 2021, the ascites has been drained off. They attributed it from the liver cirrhosis secondary to portal hypertension. So it was all drained. They put in an indwelling catheter and the patient was discharged well. This time he was admitted in April 20. He had history of admission in April 2021 because of right-sided pleural effusion. There is no cardiopulmonary disease of this patient, no renal disease as well. So initially my colleague worked this up. They drained initially about 1.5 to 2 liters of uh, large pleural effusion on the right. So initially has been treating with pneumonia. IPEMA has been rolled out. Um, Aside from that, he also trialed, according to him, TB treatment. So, but apart from those workup, the best thing that he can do is relieve the symptoms for pleural effusion. This patient underwent already series of therapeutic thoracentesis. We have already we have counseled for indwelling catheter, but he is not consenting. So this time, that's the main scenario. This patient this time and admitted under my care, mainly the same reason, right-sided pleural effusion, looks transudative based on the investigation, no cardiopulmonary disease, no renal disease. Um, Workup for TB has been rolled out. So, what will you do if you are the main provider of this patient? So, what I did, uh, we did a therapeutic emergency therapeutic thoracentesis, and we drained about 2 liters. So that's quite huge. After that, the same thing. I counseled for indwelling catheter, but he's not keen of doing so. Series of thoracentesis also required. So after that huge amount, we drained about 1.3 liters again, and the other one was 1 liter. Um, so ideally, I plan to do a talc pleurodesis, but I don't have a talc here in the island, so it's something that as a doctor, I will struggle because of that. Um, the same thing I've discussed about Angeline catheter, but he is not amenable of it. Um, yeah, that's the scenario if you're trapped in an island. Um, I was entertaining of that the recurrent pleural effusion is secondary to hepatic hydrothorax in a background of liver cirrhosis with severe portal hypertension. Note, I'm sharing this because this patient has no clinical ascites, so it's a rare case. Probably that's why it's a good case to be case report. It's a good learning point once this is properly worked up. So right now, I'm just doing giving therapeutic relief for the patient, and I'm sending this off for a CT scan to investigate further in terms of the abdomen and the lungs. But to tell you, I saw the X-ray. The effusion has resolved with a series of thoracentesis. There is no pulmonary nodules or mediastinal mass. Basically, I have not done ultrasound yet. I'll be sending this off for CT scan to evaluate the liver and some of the intra-abdominal organs. See if we have missed something else. But on physical examination, there is no intra-abdominal masses that I have found. But I can feel the liver is quite nodular. So, it's given in the context of background cirrhosis. We can find that on the physical exam. So, guys, comment down below what will you do if you're the primary doctor. I have planned in my mind already um, that this patient has to be sent out for a scan to evaluate whether there is some defect in the diaphragm, and basically, of course, if pleural duct pleurodesis is available, I will do that because right now the infection has already been rolled out. So probably in the next week, I'll send this patient in another island. It's about 40 minutes by flight to do the scan. So basically, I'll be doing the abdominal scan and the chest as well to see whether I missed something else or if this recurrent pleural effusion without evidence of ascites is related to what I believe a potential cause of recurrent pleural effusion. Though I've read in an article that hepatic hydrothorax is a complication and a difficult to manage in the context of liver cirrhosis with the with severe portal hypertension. It's about 5 to 15% case that we can encounter. In this case, right-sided effusion without evidence of ascites. So if you are a health worker, medical doctor, interns, or nurse, or any medical health worker that has background in medical, you can comment down below in this video if what will you do if you are trapped in one island, you have no nothing great facility like scans or CT scan or ultrasound. So yeah, it's quite interesting and challenging as well. But one thing for sure, I'll tell you, just relieve the symptoms and you will be fine. Yeah. Till next time, I'll update you about the scan. I'll tell you about the case. Bye.